takeaway should have been, looking at most of this for today, is that we really don't, that the body can, for the most part, until we get down to croup, the body can really heal this for the most part as long as you support and give supportive comfort care until they get over it. So there's not a whole lot of things that we can do, but there are a lot of things we do. And I'll point out some of the good and bad and why we really recommend that those things not be done as we go through. Okay, so for acute bronchitis in adults, patient comfort, don't want them to get dehydrated, don't want respiratory compromise. So encouraging them to drink fluids. It's thought that as long as you can stay well hydrated, those secretions in the respiratory tree will stay thinner, they're easier to cough up, they're easier to expectorate. So keeping well hydrated is important. If you've got a fever, then you dehydrate faster. If you're mouth breathing, you tend to dehydrate faster. So encouraging fluids is important, and using a vaporizer or a humidifier. These things are great. The biggest problem is people not keeping them clean. And so they tend to get moldy, and then you just exacerbate the problem because you just keep throwing mold out into the air. So using a vaporizer or a humidifier are good, but they do have some maintenance issues with them. Okay, for analgesics and antipyretics, so aspirin, Tylenol, and the NSAIDs, ibuprofen, I put down as the kind of the example here because it's over the counter. People can self-medicate, buy it, self-medicate. For these, I want you to know the doses, okay? Because they're common, there should be things you're somewhat familiar with, and they're just going to keep coming up over and over again. So I don't ask you to know a lot of doses, but these are just repeaters, and something you should have some familiarity with, I would think. Most people don't use aspirin anymore. They'll go to usually either Tylenol or an NSAID. For a lot of people, aspirin in the doses that we tend to recommend for analgesia or to relieve a fever usually upset people's stomach, and they may not feel good enough to tolerate that, or they've had bad examples in the past. But it's still, it's one of our best analgesics. And enteric-coated is often used by people to try to get past the stomach upset. Note the max dose there. Here's one thing I want to say about all these products that I didn't put in here, is that the problem that we get into is that they are in multiple products. As a pharmacist, I'll tell you, I don't like multiple products that have multiple ingredients. I never recommend them. It's what I ask patients is, what symptom are you having? We treat that with a single ingredient. When you start doing these multiples, what happens is that people will not realize that this one has Tylenol, this one has Tylenol, and oh, my doctor gave me a prescription for a product that also has Tylenol in it, for example. Or they have multiple aspirins, or they don't realize that Pepto-Bismol is a salicylate. And so you can get salicylism or salicylate toxicity from too much Pepto-Bismol. So it's that not knowing or awareness that these products can overlap or can duplicate is a problem. Especially when you get in the extremes of age, the elderly and in kiddos. So for Tylenol, here's the thing with Tylenol. We keep lowering the max dose because it can cause a great deal of liver damage. And a lot of the pain products that are prescription have Tylenol with them. So that is a common place where people can get too much of it. So Tylenol in large doses over short periods of time can cause liver damage, and liver damage that can kill you, okay? Especially in people who are taking multiple products of Tylenol. And people who drink alcohol, a lot of alcohol, 2 or 3, this says 3 drinks, that's the guidelines. But if they are regular intake of alcohol, or they're those binge drinkers on the weekend, then where they drink a case of beer in a weekend, but they only drink during that time, and during the week they don't. So that's where you can get these liver damage accelerated or amplified. Okay. So recommendation is 3 to 4 grams a day. The recommendations are really if you're self-medicating to stay below 3 grams a day. If you are being followed by a physician who can measure your liver enzymes, then 4 grams is the recommended. But we're going to stay with 3 as the recommended if you're for self-medicating. And then ibuprofen, Motrin, Aleve would be the common products that are over the counter. The over-the-counter dose or product strength is 200 milligrams. Now you can get prescription that are 400, 600, and 800, but the ones I get over the counter are 200. Of course, they can take multiple of those. So it's every 4 to 6 hours. Max is 3.2 grams daily. Now, the elderly. So prostaglandins are one of the mediators that keep our kidneys working like they should. Too much of prostaglandins or knocking those prostaglandins out in the kidney can lead to their inability to filter and to appropriately handle a fluid load. So you can precipitate a heart failure in people who already have heart failure diagnosis. You can certainly make that worse. So be careful in the elderly. Or those who have poor renal function, it's the same problem. Okay, so that's our major thing. Now cough and cold remedies. So cough and cold, it's really recommended that if you've got a productive cough, you don't suppress it because it's the body's way of getting out the stuff that's causing them trouble down in their respiratory tree. Just like a fever, some of the recommendation is don't treat a fever unless it gets too high. Because it's, again, the body's way of getting rid of those agents that are making you sick. But there's 3 on the market that are 3 big classes. So codeine's a great antitussive. So is dextromethorphan. That would be the ingredient in Robitussin, probably be one of the more common. Also Benadryl, the antihistamines are good at suppressing cough. Each of them bring problems. So the codeine is a narcotic, and it works centrally, as does the dextromethorphan. So they work in the medulla to suppress cough through interactions with different receptors. So codeine is a direct a suppressant. It is now considered an off-label use. Used to be that we had, and we still do, there are still products on the market that can be prescribed as cough suppressants. But then you get into abuse, and people are going to be watching how much narcotic you prescribe. What can PAs do? Level 3s through 5s? Is that? 2s you cannot, I assume. Okay. So codeine in combination with something else is a category 3. So that is something that can be prescribed. So very good, severe coughs, bothersome. People are going to complain to you when they can't sleep, when they're coughing, and that's when it usually will get worse, when they lay down and they cough so much they can't, or it wakes them up a lot during sleep, or their partner says, go get something for your cough. Or they get those coughs that you just can't control. It starts and then you cough so much you can't stop. Or you cough enough that you throw up, or you cause little blood vessels to break in your eyeballs and you get red eyes from that. So the severe coughing needs to be addressed. Dextromethorphan, over the counter, it is a codeine-like in structure, but it is a non-narcotic. And it works through different mechanisms. It actually numbs or anesthetizes the stretch receptors that are associated with coughing, and is actually a good suppressant. But they're both central acting, so their side effects are going to be central side effects. So central with depression, with the codeine, with dextromethorphan, you can actually see a more CNS stimulant effect. But it also can cause some depression and can cause problems with driving or operating machinery that you need to be more alert for. Really recommend staying away from the antihistamines because they are so drying that they can really cause kind of an accretion or a very solidifying effect on those secretions, and so it just defeats the purpose. And so even though they're effective at cough suppressant, they're really not working for us in terms of the secretion part. Any questions here? You do not have to know the doses on these. Mucolytics. So mucolytics, guaifenesin, you've got some of the Robitussin products have guaifenesin in them. Mucolytics are thought to help break down secretions and make them thinner and make them more easier to expectorate. The thing is that they've never been shown to be effective. If you look at large studies, they just aren't that effective. And some of them that are prescription are very expensive and they just don't do the job. So I don't know of anything that we're going to talk about where they are actually like, yeah, give them, they're great. They're usually not. So using like the nasal saline is very good. But in terms of, for this, they're just not recommended. They're wasting their money. It's more of a placebo effect. It won't hurt them, it's just not going to help. Use of inhaled beta-2 agonist is not recommended, hasn't been shown to help, except when you're talking about asthma. If you have somebody who has asthma and they're having wheezing and you think it's that their bronchitis is part of an asthma exacerbation, then you're going to be treating them. You're going to use bronchodilators with them. But for just general bronchitis, not associated with asthma, there's no recommendation for bronchodilators. Nor is there any recommendation for corticosteroids. So steroids and antibiotics are just some of those things that providers can't leave alone because they feel like short term, not going to hurt them. They're walking out of here with something, they think it will help. But it really does not, there's no evidence that unless you've got somebody who's got a persistent cough that will not go away, that there's no use of using steroids. The airway, and we'll talk about this when we get into asthma, the airways after a viral illness usually stay hyperreactive for 2 to 8 weeks. Okay? So that cough, I'm still coughing, I feel fine, but I'm still just can't get rid of this cough. Often it's due to that just hyper-responsiveness of the airways. It takes a while for that to kind of, that inflammation to settle down. But it doesn't usually warrant steroids in people who don't have asthma. And when we get to asthma, that's a different story. Their baseline inflammation is much higher and more pervasive throughout their respiratory tree, and so for them, steroids are a foundational piece. But for healthy adults, no problem before, there's no reason to use these steroids. You will see them used all the time now. So it doesn't always make it right. So if you say, well, I already see, this is what I see done all the time, seeing something done does not equate to clinical effectiveness. It may be for other reasons that people have done that or have developed that habit. There's no routine place for antibiotics unless you suspect that there is a concurrent bacterial infection going on. Okay? And then it's the usual suspects. So it's going to be strep, M. catarrhalis, or H. flu. So we go back to our antibiotics and our macrolides like azithromycin or amoxicillin clavulanic acid.
On the Mucinex,
Yeah,
I had always heard the same thing, like that it wasn't effective, it was just as effective as like a large intake of fluids.
right.
But when we had the viral congestion up here, the PA was like, she always starts with Mucinex. So are you just saying like specifically chest congestion versus, okay.
I am saying everywhere. Now, I would say, I'm not going to contradict her, she may, most of the evidence I've looked at is all lower respiratory. So maybe there's something out there about nasal, I don't know. But I think for the most part, that would be that's my opinion. So you'll figure it out, but I'll tell you that there's just not a lot of evidence to support it.
And she also mentioned like when she gave it, she told them to increase fluid a lot with it. So I did wonder like what really was the.
We usually tell people to do that. I mean, it makes sense that they would work better along with that.
With the antibiotic administration, would you first use the just the symptomatic treatment, and if that doesn't work, then give the antibiotics, or if they're an immunocompromised patient, say COPD, do you automatically give the antibiotics?
Well, we will talk about that after spring break. We'll talk about when to use, because we don't, in all COPD exacerbations, use antibiotics. If they're mild and they don't have the cardinal symptoms that are more indicative, and they've not really had an exacerbation in a while, we won't use an antibiotic. We'll just step up our other therapy to try to get their airways to calm down.
So when you say that if bacterial infection is suspected, that would be secondary to the other treatments not working, then you would suspect
yes,
that? Okay.
Yes, and I think you're gonna have to look at how sick are they. I mean, some people are going to have it concomitant, but they're going to look a whole lot sicker than somebody who has a viral bronchitis. A good point. You know, in the end, you will always have to use your judgment. So I always think to myself, okay, if I was in a court of law, could I stand up and defend what I have done? And they're going to look at what's usual. Were you acting in the best interest of the patient? Did you not do any harm according to the oath that you've taken? So it's all those things together. Okay, acute, let's see, bronchitis in children. No, it's not bronchitis in children. Yes, it is. Okay, sorry. All right, so so keeping the child comfortable. Treatment, this is the same table I gave you when we were talking about ears, okay? So I expect you to know that. We talked about it before, so it's that oral dosing for Tylenol and for ibuprofen. So nothing new there, same recommendations. Okay, so antitussives and decongestants, they're not recommended. So in 2008, some major things happened with decongestants and antitussives in children. There were products that were designed just for infants, just products designed for children, different dosing strength, different concentration, one so that you get a bigger dose in a smaller volume to give to like an infant. Well, there were deaths. There was unintentional overdosing, medication errors. So they took there was a voluntary removal of those products from the market by the manufacturers in 2008. Later that year, they came back and they changed the labeling. So the labeling now, if you pick them up, you'll see it doesn't recommend it for children under 4. So those things are not available. Some of the problems with kids, and especially if we're looking at like codeine in particular, I think is what I gave you, is that if you go back to one of those first lectures that we talked about how the liver eliminates drugs, we had those phase 1 reactions, that was those cytochrome P450 systems, and then we had phase 2, which were glucuronidation conjugation. All with the attempt to try to make these drugs more polar so that the kidneys could eliminate them. Okay? So taking usually more active drugs, making them more inactive, and making them more able for the kidneys to eliminate them. Okay, so children don't really reach that ability to conjugate drugs fully until they get to be about 10 or 12 years old. So these drugs that rely on that for elimination in children can cause trouble. And so that's one of the reasons why the variability in kids is, in terms of metabolism, is one of the reasons why those drugs were withdrawn. And also, I think codeine falls in that category as well. So it's really not recommended that you use these products for cough and colds in children. The recommendation I did find in the pediatric literature is that if you have a cough that, especially at bedtime, that is really problematic for a child, so 1 and up, is to use honey. Okay. But remember, honey, never give it to an infant because of the problems with the botulinum. Spores can be in there and you get infant botulism. So we're talking about kids 1 and up. Okay, and that's it for bronchitis. Any questions or anything that I said that contradicted or was not congruent with what you just heard? Okay.
As far as the not giving it to children, the dextromethorphan or the codeine, to be clear, is that like anything that's anyone who's prepubescent or anyone younger than 10 or under 18? Like what's
the only thing I found was 10 and under. Or be aware that they may not be able to metabolize those drugs. So under 4, do not use. Above 4, you can use it, but be aware that you've got your ability to metabolize it is variable and less. Okay, so let's talk about bronchiolitis in kids. Goals of treatment: maintaining oxygenation, adequate hydration, keeping the fever. I'm just going to refer back to what we've just talked about in terms of managing a fever. Bronchodilators, so they're really not recommended because for several reasons. One is that in looking at children who were treated with bronchodilators as outpatients, there was no change in the hospitalization rate. Children with bronchodilators inpatient had no decrease in hospital stay, and no significant improvement in oxygen saturation with bronchodilators. So that leads the Academy of Pediatrics to say, we don't recommend their use. Let me back up and tell you why I've given you these things. I'm not going to ask you for these on the test, but here's what you need to start to understand why those things are being said, is that this is part of evidence-based medicine. So maybe we've always used these things and everybody's just accepted it. Then people start to look at it and go, there's no difference. So these are the type of outcomes people will look. If you're hospitalized, usually you're sicker, so that's one thing. The other is that it's costly. So if you can avoid or you can decrease people going into the hospital, that's something. If you can decrease the number of days they're there, that's great, that's less money. It's also less time that you're in an environment where you can get sicker. Okay? And the stress to the child, stress to the parents, the family. So there's that part of the stress as well. So these are the outcomes that people look at, is hospitalizations, hospitalization rates, length of stay, and clinical indicators. Did you get better faster? Did less kids develop some secondary problem? Did less kids die? So those are part of it. So that's why I have put those in there, but I am not going to expect you to know it on the exam. But you ought to know why the American Academy of Pediatrics says, we don't do this. You can also turn around and tell it to parents. Well, so-and-so always admitted them to the hospital. Okay, well, here's the reasons why we don't. And things change over time. We get more evidence, we get better information, so it changes our practice. Some children, though, did do better with bronchodilators. So even though the Academy says don't use them, they are saying that if you choose to use them, at least monitor them and determine whether or not they're getting better. Well, that's kind of like duh. That should be it for anything we do. But when you're using something as controversial or where you're not sure that you're going to make any difference, you're going to try it. Maybe you don't have anything else at your disposal to use, then you just make sure that you're following them up to see if they respond. You do not have to know the doses for me. Now, I don't know what the person ahead of me asked you to do, but for my questions, I will not ask you that. I do want you to start to appreciate the difference in delivery methods. So nebulizers are great, but so are MDI. So here's kind of where we use them and when we don't. Has anybody talked to you about devices yet? Have you all had this conversation? Okay. So nebulizers, I've showed you there on the beginning. So nebulizers are a device that will they'll take the medicine and very finely divide it so that when you inhale it, more likely it's going to get down into your lungs. So a drug getting down into the lungs is all dependent on particle size. The bigger it is, the more likely it's just going to fall out in your mouth or in your trachea or before it ever gets down into the very small airways. Okay. So that's one of the things that a nebulizer will do, plus it'll add a mist usually that will make it a little bit more comfortable to inhale. So usually you're going to get the drug in those type of vials. They're going to be individualized, or it's going to be in a dropper, and you'll have the parents measure it out, and the dropper will have the dosing increments on the dropper that goes down into the bottle. If it's one of these vials that I've shown you, they just dump this into one of the compartments of the nebulizer. So if you look at that middle picture, where that mask is, right down from it is a well. And in that well, the parents are going to, or the respiratory therapist is going to put the active drug in, and they're going to usually add normal saline. And then they put the mask over the child's face. You know, if you have children, you know how well that goes over. So that's sometimes a fight. So in smaller children, you're going to do that, or you may do it in older adults who really have maybe a diminished ability to cause an updraft. Or they'll have a device or a mouthpiece that just goes in their mouth, and they'll hold it in their mouth, and they'll breathe in and out to get the medicine. So you can use a mask or a mouthpiece. Children will usually use the mask. So nebulizers are great, but they take time. They can take about 15 minutes to deliver the medicine. So 15 minutes in a 2-year-old's life is a long time. Okay? So that makes it somewhat more difficult. And they usually don't like a mask going over their face. This child they probably paid or bought off in some way to get them to do that. But see, they're holding a little thing in front of them, they're playing a game. So that's a nebulizer. Great delivery device, but it has a lot of maintenance. You have to do a lot of work to keep it clean. You got to wash the mask every time. You got to wash the tubing at least once a day. You got to soak them in vinegar, so more maintenance. Or you can do, if the person is able to breathe fairly well, you can do it by using the meter dose inhaler. Okay. And then what we do is we attach a spacer device to it that allows the big particles to fall out and the smaller particles for the person to breathe in. So either way, usually we will prefer to do it with an MDI spacer device because it's quick. We can get the dose down in a minute as opposed to the nebulizer. It's also a difference in cost. But it will depend on what's best for the patient. If they need a nebulizer, then that's what we do. Questions about that? I bet you Tiffany will talk about those tomorrow. She's really good. She works with kids all the time, so you should get a lot of pearls from her. Okay, for steroids. So the American Academy of Pediatrics does not recommend that the routine of use of steroids in children with bronchiolitis. So again, here is because of evidence. They have neither inhaled nor oral steroid have shown to reduce hospitalizations, decrease length of stay, clinical score, meaning how well they're doing clinically, or the hospital readmission rates. So no evidence lines up to show them. However, children with asthma are a different species, and so for them, we would probably use a steroid burst with them, or increase the dose of their inhaled steroids. Nebulized hypertonic saline. So normal saline is what percent strength?
0.9.
Okay, 0.9. So everything's in reference to that. So when we talk about normal saline, it's isotonic with body fluids. So hypertonic saline here is defined as 3%. There are other strengths, but this one they use 3%. And again, there's not a lot of evidence to show that it is effective, but there's no harm in using it. So it's one of those things that you can use, and if it works and helps, great. And if it doesn't, you get no harm to the child. Other unproven therapies, antibiotics should not be used. Ribavirin, we used that for years, but it has declined in use. It's no longer considered a drug that we use for kids. Leukotrienes have been tried, so montelukast has been used in these kids, and in large studies, well, I shouldn't say it, very small studies, there just has not been enough evidence to move the academy to change their guidelines and to increase the use of it during bronchiolitis. Okay, did y'all talk about Synagis in your last? You did? A little bit, okay. So,
Yes, palate
Oh,
He said the first, he said the palate is.
Synagis is so much easier to say. So we'll just go by that. Okay, so this is great treatment. This is immunoprophylactic treatment. So here, this is prevention. So everything we've talked about to this point was treatment. This is prevention. So preventing or decreasing the risk of RSV in high-risk patients. So again, whenever you see MAB at the end of a drug, that's a monoclonal antibody. These are really cool drugs. If you look on the next page, I just threw this in so you would have an idea of how these things are made. So what they do is they inject an antigen into an animal model. In the beginning, they always used mice, but they've used rabbits and all kinds of other animals. But mostly, you'll see murine antibodies, and so you knew it was a mouse. So they inject an antigen into the mouse, and they harvest out to see what kind of antibodies, or if it will produce an antibody to that antigen. And then they merge, when they get the cells, the B cells that will do that, they put it together with a myeloma cell, because myeloma cells are immortal cells. They will produce till the cows come home, until we kill it, okay? So by putting those two together, we get a hybrid cell that lives forever and produces the antibody that we want, okay? And it's very specific, so that's good. So then we can use that antibody against something in the body as a drug. And so that's what this drug does. And I gave you a video tag. It's about 5 or 6 minutes long, but I would say the first 3 minutes are the only part that's worthwhile. So this drug, or what the RSV virus does, is it has these glycoproteins that cover the cell membrane. And those glycoproteins allow it to attach to a host cell and to merge its cell membrane with the host cell membrane. Okay? So it can move in very easily, and then it can just do viral replication until the cell dies. What this drug does is it attaches to one of those glycoproteins that's on the RSV molecule. And then when the drug is attached to that glycoprotein, the RSV can sit on the host cell, but it can't enter. Okay? So that's how it prevents the infection from occurring. It's cool. So go on and look at that video. So indications are for kids, babies that are high risk for RSV. And what I want you to know is I do want you to know those indications. So I want you to know it's prematurity, so it's kids that are born before age 32 weeks gestation. Then it's the kids between, the only difference between those kids that are born a little bit later, the 32 to 34 week gestation, is that the dosing, amount of dose that you have to give is less. The number of doses is less. I think it's 3. It's 5 for everybody else. Or it's for children who have heart disease or in children who have significant lung disease. Okay? So I want you to know those indications and know that you need to start it before RSV season, which is usually starts in November. So they usually start these in October and go for 5 months. Okay? So it's a monthly IM injection. It's important, it is, if you're dealing with this population, it's important to know how that, when you start and when you end, because they're expensive, and insurance usually will only cover 5 doses. Per dose, it runs about $2,200. So if you mess up and start it at a different time and RSV season goes longer, then they would be responsible for that cost. So that's one of the reasons I want you to know it. Well tolerated. It doesn't interfere with the ability of the kid to get all their immunizations on schedule. And there are some hypersensitivity reactions to it, but they're rare. So very well tolerated drug. Does a great job. Questions about those? Okay, last thing, croup. So croup, 2 things we're going to use. We're going to use an anti-inflammatory. We're going to use a different type of bronchodilator than we have for other things. So here our anti-inflammatory treatment is dexamethasone. And we are going to use it for a couple of reasons. One is of the steroids, the glucocorticoids, it's the most potent anti-inflammatory. And it lasts 3 to 5 days. So you give 1 or 2 doses. Here we usually give 1 dose, you're done. Because the disease itself is very limiting. The problem with dexamethasone is that it tastes horrible, horrible. So getting kids to take it down is difficult. So I gave you some things there to kind of keep in mind. Some people mix it with cherry syrup, or you can get a pharmacy to use the Flavor RX. And I went online and found 3 that they recommended, just so you have them there. That's one way to do it. There is a practice in the ERs to take the IV solution and make it as an oral solution. I went on and looked at what the evidence and how, and if that is, if there's any problems with that. There were some studies, they're Canadian studies, but they did use the IV solution to make an oral solution. Now, if you look at the concentration, you can see why. Because the oral amount could be a fairly large amount depending on the size of the kid. So the IV solution is more concentrated. And it seems to be able to, it's stable enough and to be used. I do not want you to think that all oral IV solutions could be changed into oral solutions. It's because you got to think stability. You also have to think about, there are preservatives sometimes that are put into an IV solution that you may not want a very young child to have. So this is not a very common practice, but it's one that's been developed because of the concentrated nature of the IV solution. I would still always recommend oral because that's what it was developed for, but I want you to know the other because it is not an uncommon practice. One thing that I don't know that he put in his PowerPoint, but people are beginning to use nebulized budesonide, which is Pulmicort, as an alternative way to deliver a steroid. Steroids are real. A lot of kids throw them up. You give them, they throw them up right away. And that's why they don't use prednisone, because the children it tends to just be too hard on the stomach. And dexamethasone seems to be better. If you've got a kid that's throwing up and you are worried about getting the dose down, that would be the indication for that nebulized budesonide. It's the only steroid that can be given via nebulization. The last, and I'm sorry, I don't know if yours printed out funky or how it looks on your screen. It didn't look like this on the screen to me, but racemic epinephrine. So it's a bronchodilator. It's different from the beta-2s because it hits almost all it hits alpha-1s, alpha-2s, and beta-2 receptors. Racemic, there are several chemistry majors in here, if I've looked over your stuff right. So racemic, just to kind of tell you what that is and so it makes more sense to you. Racemic is when you have a mixture, a 50-50 mixture of the two mirror images or isomers of a molecule. Okay? So they're mirror images, so they are not overlappable or interchangeable, but to the receptor will take both of them. It just may not interact with them to the same quality or degree. So they use a racemic epinephrine because one of the isomers is very potent, but its effects are very short. And the other isomer, the effects are very long, even though it's not as potent a bronchodilator. So by using a racemic mixture, you get a product that works within a minute and lasts for several hours. So why this over albuterol? Well, it seems that the racemic epinephrine works a little bit better in the larynx than the albuterol, which the beta-2s tend to be more out in those smaller airways, and so you don't get, at least from what I could read and find out, is that you just get a better and more replicable dilation of the larynx, responds better. You do not have to know the dose. Again, we do it in a nebulizer. That's about it. I think that's all I have. Anything that differs from what he told you? Okay, pretty easy. Mostly don'ts. If you take out all the don'ts, then that's about half of the handout.
Sarah, you said the racemic epinephrine is a nebulizer solution?
Usually. There are some, I think there are inhalers, but for mostly what I've seen, they're mostly you nebulize, because the kids are really trying to draw air, so nebulizers are probably easier. Any other questions? Yes.
For the bronchiolitis, he said that he typically uses the albuterol nebulized solution for severe cases. Is that what it means?
Say it again.
For bronchiolitis.
For the albuterol?
Yeah, he says to use it in severe cases. Would you?
Yes, I would agree with that.
Oh.
Anything else? All right, have a wonderful spring break.
Thank
I hope you get some relief from all the study. And I'll see you on the 24th, I guess, whatever day we do.